Hello, and thank you for coming to listen to me today. My name is Ray McGrath. I'm a registered mental health nurse and I work for the Mind and Body programme at King's Health Partners. Today I'll be talking about two interventions that I've been working on that support the physical health of people admitted to mental health wards at South London and Maudsley NHS Foundation Trust. Both interventions were launched during the Covid-19 pandemic. So, it's worth mentioning at this point that the two interventions that I'll be talking about, the Virtual Physical Health Clinic and Consultant Connect, are actually part of a larger project called IMPS, which is a 3-year project funded by the Maudsley charity. The overall aim of this project is to improve the physical health outcomes for people that use trust services, but also hopefully to reduce the mortality gap of 15 to 20 years that people with serious mental illness experience. At the point of the pandemic in March 2020, IMPS had been running for about a year. For the remainder of the presentation then, I'll now discuss Consultant Connect and Virtual Physical Health Clinic in more detail, hopefully sharing some of our learning to date. The interventions both launched at the beginning of June 2020, so they've been running for just over a year, but our implementation and evaluation efforts will continue for at least another year. Our evaluation also takes into account the evolving needs of services, particularly the pressures that Covid-19 has placed on services and staff. So its design may change, but that has been highlighted in our protocol paper, which was published earlier this year in Implementation Science Communications, which some of you may have seen. The aims for evaluation remain the same, however. Our primary aim is to understand the process of rapidly implementing the Virtual Physical Health Clinic and Consultant Connect, so that if the interventions are adopted as mainstream services, then they can be optimised and supported in the long term. The secondary aims are to establish the acceptability and feasibility of both interventions, and the tertiary aims, which I'm actually not going to talk about because firstly, point 1 would involve talking about how we are interrogating our clinical systems to acquire individual level observational data, and we're in the midst of our first attempt at interrogation now. And secondly, I'm definitely not a health economist, although I will say the IMPS group does hope to have an economic paper published later in the year, so please do look out for that if you're interested. I'll describe the interventions separately because they are distinct. However, they also do complement one another. I guess at their base they do a very similar role, and that is providing mental health clinicians with additional routes to physical health advice and guidance. So looking at Consultant Connect first, here the service provides the ability for clinicians to speak with local specialist consultants by connecting them via an app-based telephone service, which bypasses the usual hospital switchboards. The idea was initially conceived for GPs who wanted a quicker way of connecting to specialists to ask brief advice and guidance questions which could then be acted upon within their limited 10-minute consultation times. But the service has now been adapted in many NHS settings across the country, although this is the first time that a mental health trust has used the service in this way. All calls are recorded for medico-legal reasons, and that has also helped us because we've been able to review as part of our evaluation. And at the end of each call, users are asked to provide a predetermined outcome. So, for example, referral avoided. Prior to the pandemic, IMPS had been gearing up to pilot the service on one older adult ward at SLAM. However, once COVID had hit, we spoke to trust leaders and they were keen to accept our offer of trialling the service more widely in an attempt to improve communications and hopefully avoid transferring patients to an acute hospital setting, which could potentially put them at more risk. Fortunately, Guy's and St Thomas Trust agreed to provide access to all of their lines, which included the adults and peds lines, and so we were able to launch in June across approximately 40 mental health wards at SLAM, providing access to around 60 plus specialities. In contrast, the Virtual Physical Health Clinic is a new service design, Originally, it had been scoped and planned during the first year of IMPS to launch as a face-to-face clinic, operating as a pilot on the Maudsley Hospital site, which at that time served 6 adult wards. The idea being that we'd provide an in-reach service that again reduced the need for patient flow transfer across the road to King's Hospital, but also meant that patients felt more comfortable in a setting appropriate for their needs. That actually originated from patient feedback during our initial scoping. But again, as a result of the pandemic, largely infection control restrictions, we were forced to move to a remote or virtual version. So clinicians can now make a direct referral to the clinic using the clinical note system at SLAM. They can request either an email, a phone or a video consultation from a general physician that we've appointed at a 0.2 full-time equivalent working kind of ad hoc or basically able to balance and arrange appointments and his commitments as needed. Rather than just brief advice and guidance that, for example, Consultant Connect offers, the virtual appointments can be offered as longer consultations. And the aim of that was to enable service users or carers or staff to be able to participate to address long-term condition management. So we've used a number of implementation strategies, but the two that I'm going to talk about are communications and user interviews. Now, fortunately, because both interventions, as I've said, are similar, and the target groups or the users of the interventions are the same, or at least they overlap, we've been able to repeat or share many of the same strategies across both interventions. So in terms of communications, I've grouped our strategies either by formal or informal. So because IMPS had been running for a year before we launched, we were familiar with the majority of formal routes. So for example, we knew how to get something published on the Trust intranet. We knew who to ask if we wanted an article to go into the weekly bulletin, and we knew if we wanted to target a specific committee who we should contact. But again, because we'd been working within the Trust for just over a year before launching, we were also able to capitalise on some of the informal relationships that we'd built with colleagues working in other areas. So, for example, we could also ask the smoke-free team who had access to all clinical areas throughout the pandemic, if they would be willing to distribute posters for our interventions and stick them up in staff areas, which they did. We also asked colleagues and friends who are doctors whether they'd share things in their private WhatsApp groups. And we also, or some of the project team, had the opportunity to come face to face with clinicians, kind of on the shop floor, as it were, and talk about the work we were doing. We volunteered in various areas like training and development, or if there were staff shortages. And that, as well as getting our work out there and talking about it, we also got some anecdotal feedback. I think the more feedback that we got as well spurred us on to collect it in a more methodical way. So we decided to undertake some semi-structured interviews with staff that had been using the interventions. And despite the pressures of the pandemic and everybody being kind of pulled in this way and that way in terms of work demands, we had a reasonable uptake, and more or less everybody we asked agreed to do the interviews, which were about 20 minutes to half an hour long. And so using the interviews and writing down the responses was useful because it's helped us to identify how things were working at various stages of implementation. So, for example, with Consultant Connect, somebody said that they didn't always get an answer, but they still preferred to have it as an option, even if it didn't work, because it was just that sometimes you call back later and then it did. But also it's provided almost actionable feedback for how we continue to refine the interventions as we continue to implement. So for a virtual physical health clinic, for example, we questioned the response times when somebody said it took too long to get an answer because their patient had already been discharged. And then at the end of the user interviews, we also asked questions about acceptability, appropriateness and feasibility, which has shaped our understanding, and they'll be included in our evaluation write-up. Reviewing usage data is also shaping how we're implementing the interventions. Checking uptake or total use figures regularly gives a snapshot of whether they're being used and working. But we've also got access to much more detail. So, for example, with Consultant Connect, I can listen to any of the calls to understand the types of queries that are being raised. And I have data, for example, like I could tell you the time it takes for a typical call to be answered. And all that extra information has helped us to tailor our messaging in comms releases so that we can improve user experience. For example, we said to people, if your call isn't answered, then hold on for at least 30 seconds before you hang up. Or if you don't get a response straight away, give at least 10 minutes before ringing back, because somebody may need to doff PPE equipment, or they may already be in a consultation. For the virtual clinic, the intervention hasn't been used as much as we'd anticipated. However, the additional data has still helped. For example, we know that when we first launched at the Maudsley site, only half of the wards were operational. The others had been repurposed for COVID overspill. We also know that the doctors that have used the service had additional comms in that we visited or rang the ward to speak directly with them. And we were able to explain what the service offered and also highlight the differences between it and Consultant Connect. We also know that patients haven't been involved in the consultations or queries that have been raised, so we are now looking at how we can adapt the service in its second year to bring it in line with pre-COVID aims. But at the same time, of course, considering the pros and cons of a virtual offering in the ever-changing kind of operational climate. So I'm going to end the presentation there to allow time for questions, but if anybody does want to get back to me at a later stage, then please feel free to contact the IMPS project team, and the email is on the slide. There's also some links to the other things that I've been talking about. Thank you for listening.